Hi, my name is David Liu, and I'm an orthopedic surgeon in training at the Harvard Combined Orthopedic Residency Program, and today I will be talking about the utility of routine pathologic examination for limited fasciectomy for Dupuytren contracture. During this talk, I'll discuss a brief background, our materials and methods, the costs related, our results, as well as open the floor for discussion. Dupuytren disease can be a functionally limiting connective tissue disorder when it leads to contractures of the digits. Less invasive treatment options do exist, but surgical excision remains an important treatment option for progressive disease or significant contractures. Excised tissue is often routinely submitted for histopathological evaluation, and the question remains, is this routine practice necessary? Historical literature suggests against routine pathologic examination of wrist ganglion cysts, femoral heads, intervertebral disc materials, tonsils, and adenoids, inguinal hernias, gallbladders, appendices, and the list goes on. Our primary objective of this study is to examine the utility of routine pathological examination of surgical specimens obtained during limited fasciectomy for Dupuytren contracture. Under IRB, a retrospective review was performed for consecutive patients between January 2010 and December 2020, a 10-year study period. Our inclusion criteria included surgical fasciectomy in patients with a preoperative clinical diagnosis of Dupuytren contracture. We excluded patients under the age of 18 years who had miscoded procedures or diagnoses, cases in which there were no extracted tissues that were sent for pathological review, cases in which there was only excision of a nodule and no contracture, and any active infection. There were 376 patients included in our study, with a mean age of around 70 years. The laterality in the infected digits are listed in this chart. Nearly half the patients presented with multiple digit involvement, and 41% had multiple digits treated at the same time. The average total fixed flexion was about 72 degrees, which is the calculation and summation of the DIP, PIP, and MCP contractures. A subpopulation of 92 patients had previously undergone a prior treatment, which included either surgery, collagenase injection, needle epineuritis, radiation therapy, or some unlisted procedure. We classified results as concordant, which meant a preoperative and pathologic diagnosis that were in agreement, discrepant, in which a preoperative and pathologic diagnosis were different but didn't change clinical management, or discordant, in which the preoperative diagnosis and the pathologic diagnosis were different and the treatment plan was somehow altered. The costs we used were calculated based on the fee charged by our institution's pathology department for a single examination of excised Dupuytren tissue performed this year in 2021. The gross fee per specimen was around $513 USD, and the estimated total cost of all the patients in our 10-year study was nearly $200,000. The results here are listed. About 97.1% of our cases had concordant diagnoses, 2.9% or nearly 3% had discrepant diagnoses, and most importantly, 0 out of 376 patients had discordant diagnoses, which means that the treatment plan did not change for any of our patients. In this slide and the next slide, I listed the 11 discrepant cases that we encountered in our 10-year search. Some of these patients, as you can see, despite being without a pathological diagnosis of fibromatosis, they did show skin and connective tissue changes that can also be found in Dupuytren tissue. Here's the rest of the list of 11 patients. Moving on to a subpopulation of revisions, 89 of our 376 patients underwent another procedure to treat a subsequent presentation of the contracture, which is 68 patients underwent one subsequent procedure, 18 had underwent 2 subsequent procedures, and 3 underwent 3 or more subsequent procedures after their initial index study procedure. Of those 89 patients, 36 of which underwent a revision surgery on the same digit. Of those 36, 30 had concordant diagnoses, 3 had discrepant diagnoses, and again, 0 had discordant diagnoses that changed their management in some way. The other 3 did not have any submitted specimens. So I'd like to open the discussion first by talking about the value-based medicine, which is the utilization of medical interventions that deliver value to the overall treatment. The unique clinical presentation of Dupuytren's allows treating surgeons to nearly universally diagnose the condition without adjunctive studies. However, we do admit that routine specimens can sometimes be indicated for serving as either documentation of the excision or to offer insight into the pathophysiology of the disease. We conclude in our study that the patient care is not compromised by abandoning the practice of routine submission of surgical specimens for pathologic examination during limited fasciectomy for Dupuytren contracture. If there's any uncertainty, there may be a role in select cases for pathological examination, but overall there is considerable cost saving by abandoning this practice. We do acknowledge that there are limitations to our study. It is a retrospective cohort study design, and the decision for sending extracted tissue for pathological review was non-standardized, which may introduce selection bias. Bivariate and multivariable logistical regression statistical analysis was not able to be performed due to only having 11 discrepant cases and no discordant cases. References are listed here, and I'd like to open the floor for questions. Thank you.